Hello everyone, I'll be talking about the laboratory investigation of blood, urine, sputum, and stool. Starting off with the table of contents, first I'll be talking about the complete blood count and the hemostatic tests, and then we'll move on to urine analysis, and finally we'll be talking about the investigation of sputum and stool. This is a sample blood report. We can break it down into three main parts: the RBC, the WBC, and the platelets. We'll be going over each of these parts separately in the next few slides. So starting off with RBC, there are two types of values that can be obtained from a CBC. The first one would be the quantitative values, and the second one would be the qualitative values. So speaking of the quantitative values, the main three values are RBC, hemoglobin, and the hematocrit. The hematocrit is the volume of blood, of the volume of RBC over the total volume of blood, and this is obtained as a percentage. And based on the quantitative values, there are two main pathologies. The first one would be anemia, which is the reduction of RBC. It's not just the reduction of RBC, it can be the reduction of all RBC, hemoglobin, and hematocrit. And polycythemia is the increase of RBC. And qualitative values are also known as RBC indices. There are three main values: the MCV, the MCH, and the MCHC. The MCV is the mean corpuscular volume. This is basically the size or the volume of an RBC. And the MCH is the mean corpuscular hemoglobin. So basically, this is the amount of hemoglobin in one RBC. And the mean corpuscular hemoglobin concentration is the concentration of hemoglobin in RBC. And in all three of these values can decrease in iron deficiency anemia and in thalassemia. MCV can increase in B12 deficiency anemia, and MCH can increase in RBC membrane disorders or pathologies. MCHC can increase in hereditary spherocytosis or autoimmune hemolytic anemia. In hereditary spherocytosis, as shown in this diagram, you can see spherocytes in the blood sample that would indicate hereditary spherocytosis with increased MCHC. Moving on to the second part of the blood report, the WBC. There are two main pathologies based on the number of WBC. The first one is leukocytosis, and the second one is leukopenia. Leukocytosis is increase of WBC more than 10 into 10 to the power 9 liters. This is usually seen in four main categories. First one would be infection. In infection, there is a left shift in leukocytosis, which will increase the band neutrophils, and also this is accompanied with fever and signs of infection and pain. Steroids. Certain patients like COPD patients and asthmatic patients are on steroid medications, and these steroid medications can cause leukocytosis. Even overdosing of steroids can cause leukocytosis. And cancer and leukemia. Naturally, leukemia will cause increased leukocytosis, and in the blood report, you can see presence of myeloblasts, and presence of myeloblasts would indicate leukemia. And extreme stress, for example, surgery can cause the number of leukocytes in the blood to go up. And moving on to leukopenia. Leukopenia can be caused by autoimmune diseases, malnutrition, and chemotherapy, to name a few. There are five main components of WBC. The first one would be neutrophils. Increase of neutrophils or neutrophilia would indicate a bacterial infection, whereas increase in lymphocytes or lymphocytosis would indicate a viral infection. Monocytes, increase of monocytes would indicate TB or a viral infection, and an increase in eosinophils or basophils would indicate an allergic reaction or a parasitic infection. Moving on to the last part of the blood reports, platelets. So again, based on the platelet count, it can be divided into thrombocytopenia, thrombocytosis. There are two main pathologies, thrombocytopenia and thrombocytosis. If the patient has thrombocytopenia, which means the platelet count is low, there's an increased risk of bleeding out. The causes of thrombocytopenia would be chemotherapy, viral infections, and bone marrow diseases. Thrombocytosis is the increase of platelet count that would cause an increased risk of clot formation. this can be due to, or causes can be leukemia, inflammatory disease, and acute blood loss, especially like in a surgery. And the second value that we can obtain from blood report regarding platelets is the MPV, which is similar to the MCV, the mean corpuscular volume. This is the volume or the size of platelets. Moving on to hemostasis diseases or tests, there are four main components of hemostasis tests. The first one is the PT-INR, the second one is PTT, the third one is fibrinogen, and the fourth one, and the final one is the D-dimer. PT-INR. Here in the diagram, you can see the coagulation cascade, and there are two main pathways, the intrinsic pathway and the extrinsic pathway. The PT-INR measures the integrity of the extrinsic pathway, which is this pathway. Normally, it's 11 to 14 seconds, but the PT value is not a standardized value, so it can change from one lab or one institution to another. So because of that, there is something called the INR, which is the International Normalized Ratio. This is a standardized value that can be used anywhere in the world. So the normal INR is 0.8 to 1.2, and increased INR would indicate the use of anticoagulants like warfarin and vitamin K deficiency, sepsis, and DIC. PTT, or activated partial thromboplastin time, which measures the integrity of the intrinsic pathway. It is about 25 to 40 seconds, the normal value, and it would increase in, again, anticoagulation therapy, hemophilia, sepsis, and DIC. Moving on to fibrinogen. Fibrinogen is right here in the coagulation cascade, and it would increase in pregnancy, and it would decrease in liver failure and DIC. D-dimer, it is one of the most important markers of fibrin degradation products. So it would indicate an increased D-dimer would indicate pulmonary embolism and DIC. This is a table summarizing different hemostatic diseases and their respective lab values. So you can pause the video and take a look at this. Moving on to urine analysis, there are three main parts of the urine analysis: the gross inspection, the dipstick, and the microscopy. We'll start off with the gross inspection. Three main conclusions can be made from this inspection: color, turbidity, and odor. Color, based on the pathology, the color can change. For example, red color would indicate bleeding in the urinary tract. Orange color can indicate hyperbilirubinemia or certain medications. And brown-black color would indicate severe bleeding or certain medications like metronidazole. Turbidity is the presence of cloudy urine. This is a non-specific marker for urinary tract infections or UTIs, and for presence of crystals in urine. Dipstick. So dipstick is basically, you can see here, a stick with strips of chemicals on it, and we can directly dip this strip in urine, and we can compare it to these standardized values or the standard model present in the container. And we can get 8 parameters from this method. The first one would be the gravity, and the gravity is obviously important when it comes to certain diseases. Like a low density would indicate diabetes insipidus or severe or excessive hydration, and a high density would indicate dehydration. And pH of the urine, the normal value should be between 4.5 to 8.0, and presence of glucose or glycosuria is an indicator of diabetes mellitus. Presence of ketone bodies can also be an indicator of diabetic ketoacidosis and alcoholism. Presence of heme would indicate hematuria and rhabdomyolysis. Presence of protein or proteinuria is an indicator of diabetic nephropathy or nephrotic syndrome. And another important marker in UTIs or urinary tract infections is an increase or presence of leukocyte esterase and increased amounts of nitrites in the urine. And finally, moving on to the microscopy, there are 5 main parts: the WBC, RBC, bacteria, crystals, and casts. The WBC should be less than 5, and increased WBC would again indicate an infection. RBC more than 3 would indicate stones, malignancies, glomerulonephritis, or presence of a Foley catheter for a long period of time. Presence of bacteria would indicate a presence of UTI or urinary tract infection. And crystals and casts, I'll be talking about them in the next two slides. So when talking about crystals, these are some of the common crystals, and the most common crystals would be uric acid crystals and the calcium oxalate crystals. And presence of crystals or increased amount of crystals would indicate nephrolithiasis. Moving on to casts, there are two main types of casts, acellular and cellular. Cellular casts can be RBC or WBC. RBC would again indicate glomerulonephritis, WBC again would indicate infection. Acellular, the most common casts would be the hyaline, the muddy brown, and the fatty casts. Again, this is a table outlining the most common urinary tract pathologies and their respective changes in the urine analysis. You can pause the video and take a look at it if you want. Moving on to sputum. So these are the most common, these are the 5 properties of sputum. The first one is the amount, which should be about 100 millimeters per day. And the consistency should be either serous or viscous. The norm would be serous. Color is normally colorless, or it can be pink. Pink frothy sputum can be found in lobar pneumonia, and brown sputum can be found in breakdown. Odor, an unpleasant smell is found in is seen in sputum, in lung abscesses and bronchiectasis, and the presence of admixtures, basically anything that can get in the respiratory tract, like tumor particles, food, blood, and foreign bodies. The main pathology when it comes to sputum would be hemoptysis, which is presence of blood in sputum. This would indicate lobar pneumonia, bronchitis, or even lung cancer. And finally, moving on to stool. So we can use the Bristol stool chart to compare the patient's stool. So basically, starting from the type 1 to type 7, starting from type 1, which is severe constipation, it moves down to severe diarrhea. So we can compare the patient sample with this chart and come to a conclusion. Thank you.